left main bifurcation PCI. So from benchmark to practice, what is the benchmark and what is the practice? And hopefully we'll have a few tips and tricks along the way. I have no disclosures with this at this point. I showed this yesterday. And I would say that this is really the benchmark based on the best data that we have at this point. This is from Tanveer Rab's and Xiaoliang Chen's paper from a couple of years ago, which shows in left main that really most lesions can be treated with a single stent, with a provisional approach, with a stent in the side branch only if it's needed. But when we have a complex lesion, that indeed two stents are indicated, and that the best data show us at this point that DK crush is the optimal stenting technique for this. How did the DK crush evolve? Well, Antonio Colombo first described this in 2003 when, as I understand, not entirely willingly, they deployed a side branch stent too far into the main vessel, into the LAD, and then had to crush it, and that became the crush. A good procedure that allowed immediately complete coverage of the side branch ostium, but in fact complicated things because now you had to wire through 3 strut layers of very thick struts at that point to get back into the side branch with a wire. In fact, in the first experience, they could only recross and do kissing balloon inflation in about 60% of cases, so in 40%. There was no final kissing balloon inflation with the crush procedure. We, at that point, were doing a mostly transradial approach, and you certainly couldn't get 2 cipher stents in through a 6 French. You can't get 2 modern stents through a 6 French at this point, not easily. So we wanted to see how to do this with a transradial approach, 6 French guides, and within a few months of that Colombo paper started to, in fact, I think my first crush was actually a balloon crush. So this was the treatment of bifurcation lesions using crush for the transradial approach using 6 French guides. And there's the description. This is actually the first case that we ever did, showing a type Medina 111 bifurcation, rather long lesion in the main vessel in the LAD, and certainly over 10. I think this would classify as a complex lesion even today for purposes of a 2-stent technique. And what we did was we deployed the side branch stent, crushed it. You can see the balloon is there ready to crush. Crushed it, and then deployed the main vessel stent, and then had to recross through those 3 strut layers, just like in the regular crush. So we knew immediately that this was only a temporary step, modified the technique subsequently, and this is the final result. However, in the meantime, Xiaoliang Chen and colleagues in China, and we weren't following the Chinese medical journal at that point, published this, the DK crush technique, in early 2005, where they found that compared to a classical crush group, they actually had a 100% success rate in kissing balloon inflation compared to just 80%. And this was basically their initial experience. This has obviously progressed through DK crush 3, DK crush 5, and DK crush 5, I just want to point out again that obviously it's a much better procedure in complex lesions. Here we see their stratification according to complexity, syntax complexity, Nair's complexity. When you have that complexity, actually, the DK crush is better than a provisional stenting technique, but it doesn't mean that it's just for complex lesions. I showed this slide yesterday. That for sure when they looked at their data stratified based on complexity, definition of complexity, the definition trial, that clearly there was a benefit to DK crush compared to the provisional approach. But even if we look at the simple definition, simple lesions, sorry, I pressed the wrong button here. We're going the wrong, I apologize. I always get in trouble with this. How do I go back? There. So, it was all going so well. So even when they looked at definition simple, there we are. There's a strong trend to better outcome with DK crush compared to provisional. So I'm not saying that all true bifurcation should be treated with DK crush, but many that are not complex by definition criteria still, many of these patients will still benefit from a two-stent procedure, and the one that we know that has the best outcomes is the DK crush. Of course, we had also the meta-analysis that suggested this compared to the DK crush. No other procedure was as good and was, in fact, inferior in meta-analysis of all randomized trials that compared these procedures. Compared with DK crush, again, all of them are inferior, perhaps with the exception of T-stenting, where certainly there wasn't the power, but it appears that there may be some equivalence with T-stenting, though DK crush still appears to be better. And why? Because this is from a patient we did a number of years ago now, which shows the excellent opening of the side branch ostium with no struts protruding into the ostium or, in fact, into the main vessel, and that was with the DK crush. So let me show you a case that'll describe how the DK crush has perhaps evolved over time. This is a case of a 90-year-old man with a history of hypertension, type 2 diabetes, dyslipidemia, obstructive sleep apnea, who early in the morning had a sudden onset of chest pain, decreased level of consciousness, no pulse, CPR was started by family, he was resuscitated, ECG done by EMS revealed an anterior wall ST segment elevation infarct. His CK on arrival was unremarkable, troponin was mildly elevated, creatinine was quite abnormal, and lactate was 6.5. He was in respiratory distress, was intubated, and brought to the cath lab where we found this, a Medina 111. In some views it looks like a 011, but it's a complex, somewhat calcified left main bifurcation, and he's hemodynamically barely stable at this point. Severe ostial D1 lesion as well, which you can see right here, diffusely diseased vessel. I never know what to do with all of this distal stuff, and I tend to leave it alone. I don't think you can fix all of that. The important thing is to get the proximal vessels, which are the ones that are causing the problem at this point. So for sure, a complex case. This is his right, thankfully unremarkable, and there is the evidence of the acute anteroapical infarct with a large wraparound LAD. So we wired both of these vessels, initially a 2.5 millimeter balloon in the LAD, 3.5 by 15 NC in the circumflex, then in the LAD as well. And this was our result post 3.5 NC balloon. We now had stability. We opened the major problems, which was the ostial circ and the ostial LAD. So we had some stability. Before going on to the left main, we now needed to treat the distal vessels that we were going to treat, which was, in this case, the LAD. So I did want to preserve the diagonal. It was larger, rather a small caliber vessel, but not a small distribution based on its length. So we went with a 2 by 15 balloon. Then we optimized the entire proximal LAD with a 3 millimeter Wolverine cutting balloon, and had this result We deployed a 2.75 by 15 Resolute Onyx DS in the mid to proximal, and I was very happy that the diagonal stayed open. This is what I was trying to achieve by protecting it and by dilating it. My fear was that if I had not dilated, I might lose it, in fact, after stenting in this case, even though our usual recommendations are not to touch side branches if we're planning to do anything with them. In this case, this was a very severely diseased, diffusely diseased vessel. I just wanted to keep it open, not to intervene on it in any way other than the balloon that was dilated, inflated in the ostium. So now we've done the mid-LAD segment, we've optimized the proximal LAD. It's time to head to the left main bifurcation. This is a 3.5 by 12 drug-eluting stent. It's a little bit proximal, and I think I probably, after this, advanced it a little bit. I don't like to have 4 struts. A couple of struts is enough into the left main vessel. So we deployed it, inflated it, and after deployment, I usually pull the balloon back a couple of millimeters, do a higher pressure inflation to ensure that we have optimal expansion at the ostium. And then we do the crush, okay? The crush is with the 3.5, with a balloon sized for the distal main vessel, so for the LAD. I've also done a variation where I actually do a pot crush, where I'd place a left main sized balloon right at the distal edge of the, right at the carina, and do it that way, and that saves one step, but I would say do the usual stuff, which is do the crush with the normal vessel and then do the pot with a balloon that's NC balloon that's sized for the main vessel. In this case, we used a 4.5 by 8 millimeter NC balloon. Why do we do that? Why do we do a pot crush? A very simple reason. If you don't, the left main vessel is larger and you will have, your stent won't be well opposed. And so when you're trying to recross, not only may you go abluminal, but you may in fact go right through the true lumen of the stent. So here we see what happens. This was done at the lab in Minnesota, the Living Heart lab, but we don't unfortunately get this kind of images of our patients. But so here we have deployed the side branch stent, and here we are crushing it with a 3.5 by 12 millimeter balloon. Okay, so we crush it, and what happens when you remove the balloon? You have this. So what is the chance really of getting a wire through the struts rather than into the lumen of that stent? Very not great, I would say. So that's why sometimes you still have difficulty wiring. So now we go with the balloon that's sized for the main vessel, for the proximal main vessel, and look at what happens. So this is now a 4.0 balloon, and after the crush, we actually now have a true crush in the main vessel. Okay, and now you can actually see the bifurcation. Your bifurcation, your ostium is actually now more open. The angle is more favorable for you to rewire and to bring a balloon into the side branch. I think we have a few minutes, right? Yeah. So this also makes it much easier to wire. And here's just a demonstration. Again, we don't want to go distal. We want to go mid to proximal. Of course, I can see where I'm going here, which I usually can't. But very easy to rewire in a mid to proximal cell. And so here, in this case, back to our case, we're very distal. We're too distal, and I'm unhappy. So I will actually take this wire right back and go through a more proximal cell. So what happens if you don't is that if you do this, you can actually go abluminal relative to the stent and avulse the stent from the distal wall, if you wish, of the side branch, and end up with an unstented portion at the ostium, which is not good. So you want to do this. You want to be proximal to mid with your initial rewiring in the DK crush. That's very important. So we did this, and now watch what happens to the balloon. This is a balloon that's already been used, and it just flies right across that crush stent that has been optimized by POT through into the side branch. So we recrossed actually with a 3.5 by 15 balloon, which I think before POT I would have found unheard of, and I do a lot of DK crush. We positioned the balloon again in the main vessel, 3.5, 15 NC. I don't kiss first. I always open the struts of the side branch stent first at higher pressures, and then I do low pressure inflation, kissing balloon inflation. Then we position the main vessel stent, having optimized everything. Obviously, we're going to overlap with the mid-vessel LAD stent, and in this case, there's disease right to ostium of the left main, so we're actually go ostial with that balloon. And once we deploy this, we do a second pot, again with a 4.5 by 8 millimeter NC balloon. We recross. This time the rewiring can be more distal because we've already ensured that we have that the entire ostium is stented with our first proximal wiring, if you wish, and inflation there. So this time it can be more distal. Otherwise, if you go proximal again, you end up with a very bulky neocarina. So that's not optimal. And we once again optimize with high pressure inflations with the 3.5 NC balloon to optimize the proximal LAD and end up with a second kiss, again low pressure 8 to 10 atmospheres. And so this is just a trick I want to show you, since this is supposed to be about tips and tricks. In this case, after the deployment of that, even after POT, I could not get a balloon. I could easily rewire, but I could not get a balloon, a brand new balloon that was in the lab of this particular company. You can see how difficult it is. So what I do is I inflate the balloon and that kind of pries open the struts in this case. And watch what happens. So we deflate, we push a little bit more, inflate again. Okay. And now watch what happens. The balloon flies through, even though you could not get it through those struts initially. So I think that's a very cool thing that you can do. And there's our final result, and a very stable patient at this point with a nice DK crush result. I don't necessarily do a final pot because I've already done 2 pots with a large balloon, and I'm only doing a low pressure kissing balloon inflation. So I think what I've done with that pot is going to be quite adequate at this point. So I don't necessarily do a pot unless I'm concerned. If you do that pot, you need to stay away from the carina. Okay, so it's a more proximal pot than one you would have done earlier. So to summarize, current consensus is that provisional stenting is the preferred technique for the majority of patients undergoing PCI of left main bifurcation lesions. Based on current randomized trial data and meta-analyses, the current benchmark 2-stent technique is the DK crush. The DK crush has evolved since it was first described, as I've just shown you, and we have presented the current best practice for the DK crush that may in the future result in even better, hopefully, clinical results than those observed to date. Now, so far, this has been shown by one group in one population, so we're hoping to do a Pan-American trial called Access 1, and looking forward to final approval of funding from a sponsor. And if that happens, we'll have a 450-patient, multi-country trial looking at DK crush versus provisional stenting in higher risk. Not definition higher risk, but higher risk left main and non-left main bifurcations. So thank you for your attention. Hopefully this was helpful.